Hello and welcome to CIO Magazine interview series. My name is Andy Sajus and I'm one of the field CTOs at AHEAD. And we're here partnered with CIO Magazine in a series of interviews with today's data and technology leaders. Today, I have the pleasure of talking with Jim Venturella, Chief Information Officer at West Virginia University Health System. Thanks for joining us, Jim.
Thanks for having me.
Great. So Jim, tell us a little bit about yourself and West Virginia Health System.
Sure. I'll start with WVU Medicine, which is our brand name for the health system. We're a 17 hospital system based out of Morgantown, West Virginia. We are the largest health system in the state. We have about 22,000 plus employees, which also makes us the largest private employer in the state. Granted, it's a smaller state, but we're the largest one in the state. We also have some operations within Maryland, Pennsylvania, and Ohio, some smaller pieces that we've been growing over the last several years. For myself, I've got a little over 30 years within the healthcare industry. I've been at WVU Medicine as the CIO for a little over 6 years. Prior to that was at another large health system, and then had a number of years in consulting, split between Deloitte and Accenture.
Great. Thank you. So over the past, I'd say 12 to 18 months, we've seen a significant shift in regards to the challenges that healthcare systems have met. How have you seen technology become a supporter of the business goals in ways that were maybe not met before?
Yeah, so it certainly has been a crazy time in healthcare, like everybody in the world, but I think healthcare experienced it a little more intense, especially early on in the pandemic as it hit last March. So for us, it wasn't a lot of brand new capabilities or technologies, but expansion on some things we had in place. And I think probably the biggest thing for us when things hit last year was around telemedicine, which lots of healthcare providers had to take on a lot more delivery of services through a virtual method. Now, we had the infrastructure in place and we had a small number of providers taking advantage of telemedicine, but nowhere near where it got to. And just to give some perspective, last February, we did probably 200 virtual visits in the month of February. By April, we had done 56,000 in the month of April. So it was a tremendous ramp up. We would have, it was a struggle just to get that many people trained up, get technology deployed, lots of workflow issues, lots of data needs and analytic needs to understand what was going on and how things were working. So the team did a tremendous job of scrambling to get that all into place and do it very successfully. I think the other thing from an analytics standpoint, over the last year and a half, there have been a lot of unique needs in how we leverage the tools that we had. It started with supply chain needs back at the early part of the pandemic. We had different methods of getting supplies that weren't normal. And so tracking how things were getting here, whether it was masks or other supplies, we're coming through unnatural supply chain methods. So we had to implement some tools and tracking to know where we were, where it was going, and what the needs were, and communicate with others in the supply chain around that. COVID testing was all brand new on how it was being deployed. We were setting up tents in parking lots and being able to track what was going on, being able to communicate with the government on what's going on when nobody knew how to communicate with each other at that time was certainly challenging. And then when the vaccines came, trying to support the vaccine clinics on how we were doing that and connecting with patients, the schedule, to how we were tracking. And then from a reporting, we had really three unique needs, because internally we had our own sets of needs on how we were going to track, report, monitor what was going on in these different areas. The state had a different set of requirements on what they wanted from us to report. And then the federal government had another set of requirements that weren't all aligned. And they weren't all set from day one. They were changing and evolving. So the team had to be really nimble in what they were doing and how they were developing to get to the end goal in all those different areas. So it's been quite an interesting year.
No, that's great. I appreciate that. That's good information. In regards to data and analytics, for someone in your role, what's your number one priority?
I would say number one is to try and make sure we take full advantage of what we have. We have a ton of resources at our fingertips, and it's trying to make sure that what we know we have from an IT standpoint, we actually get into the hands of the operational and clinical users so they can take most advantage of it. So what we did probably 2 to 3 years ago now is we reorganized our analytics team to try and really support that goal of getting better information into the hands of the people that really need to make the decision. So we took our centralized team and we divided them to align with service lines. So all of the major clinical and business service lines within the organization have one to several people aligned to them. And it's really delivered benefits in several areas. It's, from my team internally, they've got a much deeper understanding of the actual data, how the data is being used, and how the data can be used to support the business or clinical operations. For the leaders in that area, they've got a direct connection back into my area versus a large pool where they feel more comfortable, connecting to that person on a real-time basis. And where they're trying to build out and define what their needs are, they've got that direct communication to them. And then from a priority standpoint, the priorities change constantly. And so we're able to be more nimble and change what we're doing, what we're working on, and how we're addressing things through that relationship that we've built. And by having it still within a central area, we still get the economies of scale of having the people all together, common understanding of the tools, making sure that we're standardized across what we're delivering, but still have that, a decentralized feel for the operational leaders that they've got people they can rely on to support their part of the business real time. So that's been a huge success for us to be able to deliver.
No, that's great. And I think you kind of jumped right into my next question. So kind of just to elaborate on what you said there, how much of it do you feel like, at scale, is it education? Do you spend a lot of time in your role educating your users around what's available to them or what you possibly can provide to them?
Yeah, we actually do. There is a big gap in understanding across the board, and as we've grown, it's become more evident. We knew that data literacy was an issue, and understanding of just the tools itself, what they can do with it without the organization was a gap. And we thought it was a narrower gap, from our perspective within the organization. But as we've grown, we've added very large hospitals and smaller hospitals, and the needs and understanding at each one of them, are very different. And even within those organizations, we get a great diversity of understanding. So the team has had to really adjust how they educate. They thought it could be a little bit more standardized and streamlined than it actually is in reality for how we get people to a higher level of understanding. The other thing we've done from that perspective is try to be more proactive. The analytics team I should back up. When we bring in new organizations, we try to standardize on our common set of platforms and applications relatively soon after they join the health system. And the analytics team would come in after the fact, after we had the standard portfolio in and all the applications rolled out, and then they would start to focus on, trying to improve the use of analytics. What we found is that it's a lot more beneficial to actually have them come in even prior to the conversion. They kind of had their mind, they needed to be on the core platforms before they would come in, but having them start to educate the leadership even before they go through the conversion, and we found is really beneficial. So that's a lesson we've learned along the way. So even though they don't have the tools in hand, just starting to prep them for the tools and understanding what the transition is going to be like is been very beneficial.
That's great. So Jim, on that note, in regards to the way you've educated your user base, what are some tips and tricks that you've done internally at W Medicine?
I think the one thing that comes to mind is our use of our self-service tools. We've got several different options that we can deploy to the users or operational leaders. And we try and tailor that so that we've got some more basic tools if the user is a little less sophisticated with the use of technology or data, to some areas that really want to get into doing their own thing. We've got some more advanced tools and capabilities to put in their hands to allow them to be more independent. And with all these self-service tools, the great thing is it doesn't put the systems at risk. It's one of the concerns of putting too many tools and decentralizing them is that you can cause performance issues, other data issues. But the self-service tools give them a lot of capability without the ability to cause some harm on the back end. And by having different levels of tools that we can deploy, we can hopefully address a lot of the different needs based on their capability and sophistication.
Oh, that's really neat.